Welcome to our podcast, Multiple Myeloma Morning Commute, another tool in the RRMM Toolbox. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Oncopeptides and Sanofi Genzyme. In this episode, Dr. Ravi Vij and Dr. Thomas Martin take a look at one of the newest drugs for the treatment of multiple myeloma, the just-approved melflufen, which is the newest in the class of alkylating agents. Drs. Vij and Martin will discuss the clinical data that led to its approval and the patients for whom it may show benefit. Information about the faculty and disclosures can be found at morningcommutepodcast.com/multiple myeloma 3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Vij is a professor of medicine in the Division of Medical Oncology at the Washington University School of Medicine in St. Louis. Dr. Martin is a professor of medicine in the Division of Hematology Oncology at the University of California, San Francisco. I am Candace Hoffman, managing editor of Morning Commute. Dr. Vij will begin our discussion.
Hello, my name is Ravi Vij. I'm professor of medicine at Washington University School of Medicine in St. Louis. Today I have with me Dr. Thomas Martin from the University of California, San Francisco, and we're going to talk about a recent addition to our treatment tools in multiple myeloma, namely a drug called melflufen. Welcome, Tom.
Hi, Ravi. Thanks for having me.
It's a pleasure as always, Tom. So I think we continue to have more and more drugs in myeloma. 2021, we're just barely 2 months into it, and we have a new addition to our armamentarium here, melflufen. So obviously this is a drug of the class of alkylating agents, but it's also a targeted alkylating agent. So can you tell us a little bit about what is unique about this drug compared to other alkylating agents that have been very successful in myeloma for a very long time now?
Yes, thanks, Ravi. You're right. I think we're talking about an alkylator therapy that we've been using since, basically the 90s, right? But this one actually is quite unique, in fact. So this is melphalan flufenamide, and it basically is a lipophilic alkylating agent. This lipophilic structure attached to the melphalan moiety of the molecule allows it to actually enter into cells quite readily. So it readily enters cells. Now, this moiety that's attached actually can be cleaved off the alkylator-based therapy with aminopeptidases. And these aminopeptidases are high expression in cancer cells like myeloma. Normal cells don't have a lot of these. So in normal cells, this alkylating agent can get in the cell quick, but it can get out of the cell quick. So it's pretty actually interesting compound. Now, it works very well in the test tube, and it can work in even alkylator-resistant cell lines. And it can also work, they've shown, in alkylator-resistant patients. So based on the preclinical data, which again was very important data, this led to initially a phase 1 study that led to the dose of 40 milligrams of melphalan flufenamide plus weekly 40 milligrams of dexamethasone, and to a large phase 2 study called the Horizon study. And the Horizon study took patients with relapsed refractory myeloma that were refractory to pomalidomide or an anti-CD38 antibody. They had received 2 or more prior lines of therapy, and they had good performance status. And they received melflufen plus dexamethasone. Now, this was actually a large study. In fact, involved a lot of patients with triple-class refractory myeloma, patients with extramedullary disease. And in the intent to treat, there was 157 patients with an overall response rate that was right around 30%. And this was actually a really important study that obviously led to its approval based on its activity in this heavily refractory population of patients with actually great, in my mind, really great a safety profile. Most of the stuff being blood count suppression. What do you think about the data, Ravi?
I agree that, we've used alkylating agents for a long time, even when patients become triple class refractory. They form, in a lot of patients, a mainstay of therapy, and they've served us well. So to have another agent, perhaps better than ones that we've had before in this class, is an advantage. I think this drug will have a utility, certainly in these later line refractory patients. One of the things also that has been emphasized with this drug is that patients with extramedullary disease, which is often becoming more of a problem as we have patients progressing on multiple lines of therapy, are responding to this drug nearly as well as those who do not have extramedullary disease. I know that sample size is too small to make any conclusive deductions in this regard, but it's an intriguing observation. What do you think, Tom?
Yeah, actually, it's very active in these quite refractory patients, including in patients that had high-risk cytogenetics. So 59 of the patients actually had high-risk cytogenetics. And there was actually also quite a good response rate in the patients who had high-risk cytogenetics. The overall response rate was right around 20%, with a clinical benefit rate of around 37%. So again, very active in this refractory population. And it is going to be used in the patients who have failed pomalidomide, or failed carfilzomib, or failed the CD38 antibodies. That's where it's going to be used at the current time. And this is actually a really nice response rate in that population of patients.
I agree. We have to be a little cautious about the myelotoxicity seen in the trials. I think that patients have to be supported with growth factors. And I think that when you have very refractory patients, the marrow reserve may be diminished to start with. And so one does need to have an eye on the blood counts as one treats patients with this drug. But the drug is obviously moving into combination therapy as well. And we have, in the anchor study, the drug being combined with bortezomib and daratumumab, and I'm sure other combinations are going to follow. So what do you see in terms of the future application of this drug in combination therapy?
I think its response rate in the refractory setting is high enough that I would try to put medications like daratumumab and do it in an earlier line of therapy, 1 to 3 prior lines of therapy. Also, the favorable administration of once every 4 weeks, I think it actually might, in fact, be able to use frontline therapy, and in some patients that are not transplant candidates. I think potentially it can be combined, perhaps, with daratumumab in the frontline setting in the patients who are not eligible for stem cell transplant. So I do think it's working in the relapse refractory, in the heavily pretreated, but I think we have to test it in the earlier lines and also in the newly diagnosed.
It's interesting you mentioned the combination with daratumumab, because the phase 3 Lighthouse study, that is the larger study that is being done for this drug, is actually looking at this drug in combination with daratumumab and dexamethasone and comparing it to daratumumab alone. So yes, I think that this combination is likely to be a commonly used one potentially in the years to come. Another area where we do use melphalan a lot these days is in stem cell transplantation. So can you speculate as to how this drug could perhaps even one day be part of our stem cell transplant paradigm?
Absolutely. So like I said earlier, the main toxicity in patients who receive this is blood count suppression. So mild anemia, mild neutropenia, mild thrombocytopenia. And one of the advantages, again, is we think it gets into these normal cells and then gets out of the normal cells. Patients don't have any hair loss, which is interesting with this also, since it's an alkylator-based therapy. And actually, it's a relatively good dose of an alkylator-based therapy. The big question for all of us is, can we use this in addition with stem cell transplant? Well, this formulation, probably not, but they are going to develop a novel formulation, similar lipophilic drug together attached to the melphalan moiety. And that can be given and used with stem cell transplant. And I think they are planning to do studies in the next year or two in that realm. And our hope is that, potentially patients may not have, significant hair loss. They may not have as much blood count problems. They may not have as much GI toxicity. That would really be amazing, actually, if we can use this drug and have those outcomes in stem cell transplant. I think it'd be a huge win for us in stem cell transplant.
I agree. And I think that the other phase 3 study that is ongoing is the OCEAN study, combining melflufen with dexamethasone and comparing it to pomalidomide and dexamethasone. And I think that this is a study that, like a lot of other studies that have been done with pomalidomide dexamethasone as a comparator, will likely lead to the full approval of the drug, given that it has accelerated approval at this time. Now, where do you use alkylating agents? Because I suspect that at least in the immediate future, we are going to incorporate this drug, perhaps in lieu of some of the alkylating agents that we currently use. Which are the alkylating agents that you use today? And if so, in what combinations?
Yeah, so that's a really good question. The way we set up our sequencing of drugs at the current time, as you know, after patients have had 3 or 4 prior lines of therapy, they've received all the big 5, the CD38 antibodies, the immunomodulatory drugs, the proteasome inhibitors. And then in my mind, what's left really are alkylator-based therapy. And we tend to go to alkylator-based therapy at that time. Our common alkylator-based therapy is for us to use infusional cyclophosphamide. Infusional cyclophosphamide causes a lot of toxicity. It causes complete hair loss for patients. It is active, but it's toxic. I actually think we're going to replace that component of our therapy with melphalan flufenamide. That's where we're going to use it. Where we would use cyclophosphamide and fractionated IV doses of cyclophosphamide, we are going to use melflufen instead. And I'm hoping it's going to save a lot of hospital stays and actually a lot of toxicity.
I agree. I think that another alkylator that I use often is bendamustine in combination with prednisone, and this would be an option for patients in lieu of that drug as well. We know that alkylating agents are something we turn to when we want quick results. We have a lot of patients, especially in later lines of therapy, that progress relatively rapidly and sometimes can't even wait to get some of the other classes of drugs, and you need to have them get a treatment within the next often 24 hours. And alkylating agents, I think, is what we rely on for quick responses when we want patients to respond quickly. I think that this class of drugs is something that has a role today, even in the era of more targeted therapies. So it is great to see that we have a new agent in the old mainstay of alkylator-based therapies. And I think that this is a drug that will have utility. It is easily administered in community settings. Some of the drugs may be a little more challenging sometimes for community physicians to administer. And I think this one will certainly fit the bill for those who need to be treated in the community as well. Tom, once again, I thank you very much for this discussion, and I am looking forward to even more new drugs coming down the pike. Thank you.
Thank you, Ravi.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/multiple myeloma 3. For all the episodes in this 6-part series, please visit morningcommutepodcast.com/multiple myeloma. Thank you for joining us today.